start the recording now. I should get going.
All right.
And I'll see people coming in. I'll keep an eye on the people coming in.
Yes. All right. So welcome everyone. Thank you so much again for being here with us. We are really excited to share our session with you today. My name is Daisy Rosales and I'm the co-founder and executive director of BRIO. We partner with community organizations to design mental health promotion initiatives.
And I'm Chris Underhill. And I am, in this particular context, the chair of the Mental Health Collaboration for Catalyst 2030, social entrepreneur in the field of mental health, as well as in a number of other fields, for example, disability. And I'm a professional mentor.
And we are both part of the Mental Health Collaboration at Catalyst 2030, which you'll get to hear a little bit more about at the end of the session. And so just a bit of a preview on what you'll be hearing today. We'll be setting up the conversation and then you'll hear 3 case studies. It's our honor to welcome Monira Rahman, Peter Yarrow, and Kate Leventhal. And then at the end, please do stick around because we'll be sharing some resources and your invitation to engage with us further. So without further ado, we'll dive in with a really basic question. Does mental health really matter? Some of us might feel like mental health has become a bit of a punchline or a scapegoat for when things go wrong in society. We can also quote a number of different statistics to each other that are pretty concerning, such as the loss of productivity and the economic cost of mental ill health, or even just the fact that the WHO is estimating a 25% increase in anxiety and depression since COVID-19. But for those of us here who are already working on really important issues, we might be wondering what mental health has to do with us. And so those of us who are working in SDG contexts, many of us are aware of realities that are incredibly difficult to face. There's violence, injustice, oppression, a lack of access to resources. And we know at a personal level, at least to some degree, how hard it is to live in a world with these kinds of realities. And we know how hard it is sometimes just to get through a single day. And so that's why we want to connect mental health to these environments. At its core, it enables individuals and communities like ours to continue to do what matters to them, even in the presence of pain. And so mental health matters in the pursuit of all the SDGs, which embody to some degree our vision for a world where everyone can thrive. And now Chris will give a bit of a background on mental health and development before we dive into our case studies.
Sure, thank you for that. So I think the main thing that we want to kind of portray, and particularly with the use of these case studies, which we're about to start introducing from Kate and Peter and Monira, is I think originally the mental health has traditionally not been viewed as an issue that needs to be addressed at the level of other developmental issues, for example. But what if mental health as a pillar was seen as a pillar amongst other pillars in supporting the sustainable goals for development? What if that was a question? And so what we're looking at today is the way in which the SDGs are influenced by, intersectioned by mental health overall. So this is really, in many ways, a discussion or a talk about mental health and development. So Daisy, I would like to now go ahead and introduce Monira, if that's fine by you. And so Monira, it gives me great pleasure to welcome you as the founder and executive director of Innovation for Wellbeing Foundation, and indeed the country lead for MHFA, Mental Health First Aid Bangladesh. And you are also the managing trustee, Bangladesh Mental Health Network. You're most welcome, and we look forward to your presentation right now.
Thank you, Chris. May I request Daisy? Yeah, thank you. Well, I'm from Bangladesh, as you said, and Bangladesh is celebrating its 50th anniversary of independence. And we have transformed from being a bottomless basket to a middle-income country and aspiring to be a upper middle-income country by 2031. So it's an inspiring story for growth and development for Bangladesh. And therefore, I'm saying that though mental health is a distressing issue in many countries like Bangladesh, but our story will be inspiring. It's a positive story. So I'm assuring you to that. So based on my experience with my sister becoming mentally ill with severe mental illness, returning from her in-laws to our family, and that was very, very shocking, obviously, for the whole family. We didn't know about anything. It was 1981. And then I was encountered with mental illness when I was started working in a government institution for homeless people, and hundreds of women were, living with mental illness, institutionalized, and there was no services. And then in 1997, I met acid survivors, and many of you may know about acid violence. It's a global issue and how horrific it is. And then there was no support services, no system, nothing was there. No, people were not aware about acid violence. And then we started Acid Survivors Foundation in 1999. And it was a very successful model, biopsychosocial model, a comprehensive integrated model that we have been able to introduce from the scratch, which was a world model. And the number of acid attack was reduced from 500 per year to below 50. And then I decided to form another organization called Innovation for Wellbeing Foundation, just to focus on mental health, because there is no health without mental health. There is no development without mental health. There is no SDGs without mental health. So we have to do something, and there was nothing in Bangladesh as such. There was only, like some sort of psychiatric treatment, and the Lunacy Act. You can imagine when we say Lunacy Act means we consider these people are lunatic, and therefore, they have to confine. And this Lunacy Act 1912 was there for 106 years until Innovation for Wellbeing Foundation did, advocacy and formed Bangladesh Mental Health Network, a common platform for everybody to work together. And we have thoroughly consulted about what should be in this new act that we are actually aspiring for, and which voice should be heard in this new act. And in that way, through this consultation, we developed an alternative act. In 2014, we started our journey, and we worked with the Law Commission very intensively, and finally, in 2018, Bangladesh passed Mental Health Act 2018, which is far better than what was in Lunacy Act, acknowledging the accountability of the state for looking after the person with mental illness, but it was still mostly medical model that considered. So we continued our advocacy and developed a national mental health policy in 2019 and a mental health action plan for 2021 to 2030, which is still waiting for the pass by the government. But these two documents, the policy and the action plan, which is actually recognizing that mental health is not just a health issue, it's a development issue, and it needs community-based mental health care services. It also acknowledges that we need to develop a different level of human resources for meeting the needs of the country, because in Bangladesh, we have mental health services only at tertiary level. Therefore, there's no mental health services at district and below level. And also, it is important, just can go back to that, I will come back here, Daisy. And then it's also about like, it needs an integrated approach. So it's not just the health ministry should lead this process, but in an intersectoral way that will be addressed. So government has acknowledged this, there should be a specific ministry and a department under the non-communicable diseases, and also government has acknowledged that there should be a specific fund allocation for achieving the action plan, which is very important. We need a dedicated fund for that, and I think it is taking time because of this resource allocation. But the good thing is that World Health Organization has taken multi-country special initiative on mental health, and Bangladesh is part of that. And already some resources has been allocated in Bangladesh for capacity development. Next one. And this is actually, I would like to mention that it is important to look at from Bangladesh context, where there is very little human resources, trained human resources. We have only 250 psychiatrists for 170 million people. And these psychiatrists are only available in the capital city or big cities. So there is no services in the community. Or at grassroots level. And also in the service that we have is much more like psychiatric treatment, not as a comprehensive integrated mental health model is there. Therefore, we are working together for creating a model and reducing stigma, and also decentralizing the mental health services for ensuring that everyone, no one is left behind, and everyone from rural Bangladesh and even in urban setup, this is accessible, this is affordable, and this is also a comprehensive treatment procedures that we have. And the policy and the action plan is actually guiding in that way. And we have this mental health first aid program, which is an international program. And obviously I should say that it's a evidence-based program, but culturally we have adopted that for Bangladesh. And we have implemented that in rural and urban Bangladesh for schools, for workplace, and for community. And we have seen that it is actually changing not only the knowledge and perception about mental health, but also the attitude towards dealing with mental illness. And we have already 74 trainers who are training mental health first aiders, and we have 5,000 mental health first aiders who are certified mental health first aiders, and 10,000 mental health champions. Why I'm saying this is important, because in Bangladesh, as in rural areas, there is no health service providers trained on mental health. So mental health first aid is very important. The first point of contact is like faith leaders or teachers. So it is important that we train people like, who are the first point of contact. And therefore we have done a special program on training teachers in schools, and there is no mental health services in schools as well. And the number of suicide among young people has increased, and during the COVID, a number of research is showing that how our young people are affected with depression and anxiety. And therefore it is very important that we train our teachers. And this program, mental health first aid, has been evaluated by Imperial College London and found it very effective, and therefore it has been suggested in the mental health action plan by the government. And I would like to conclude my word that I say that it's a inspiring story, and Bangladesh government for the first time has included in the national curriculum for school mainstream national curriculum. They have included well-being, students' well-being as a chapter, as a separate provision. And therefore, there is a huge need for training teachers, and mental health first aid will be an excellent opportunity for training teachers, parents, and students, not just building their knowledge, but also changing their attitude towards mental illness.
Yeah.
And we'll be able to reduce the stigma.
Thank you so much, Munira. Thank you so much. And one thing that I'm really noticing is the role of legal advocacy and how that connects with human rights across the board. So thank you so much for highlighting that connection with that SDG, and of course, the role of mental health in quality education. We'll hear a little bit more about education from Kate. For now, I'd love to introduce Peter. Peter is the Executive Director of Basic Needs Ghana, and he will be sharing with us about the role of mental health and livelihoods. Peter, feel free to unmute yourself.
Thank you very much, Kate and Chris.
Pleasure.
And I'm glad that participants in the webinar are familiar colleagues and some professionals and experts in the field of mental health. So that is comforting, if I could put it that way. For Basic Needs Ghana, who I would say you, Chris, has been a very key part of, has been operating since 2002, and the basic premises of mental health and development was a recognition that we cannot continue to talk about development without mental health. And so I would say even before, nothing about us without us, the basic needs model had recognized that. So you would see the vision of basic needs is that people live in dignity and satisfy their basic needs and exercise their basic rights. We want to work with others to build initiatives that are likely to involve people with mental illness or epilepsy and their caregivers and communities and other organizations to enhance self-determination and influence public opinion. And as Munira had it, we are in context where mental health is least thought about. Until 2012, Basic Needs was working with the 1888 Lunatic Asylum Act. These are all colonial relics. And our health system have been modeled in such sense to prioritize more about communicable physical conditions than mental health and psychosocial related conditions. So Basic Needs in the scene has projected mental health as a key part of health and development. And that's what we've been doing all these years. Next slide is to show our approach to of work, which is that work in areas of mental health should have active participation of individuals with lived experiences and their primary caregivers, and actions should be within the community settings, as it is a key part of eliminating the stigma, fear, and other erroneous perceptions that are associated with mental health conditions and people who are living with mental illness. And so we situate our work within the community setting, and that is a key part of maximizing community resources. Family members, neighbors, friends, interested sympathizers play a part than just a doctor and a nurse, and that's it. All these in one way or the other play their useful role. And the key part again about this model for mental health and development, which we have tried to work and to improve care and support within community settings, is the active involvement of people with mental health conditions. In fact, they dictate the pace, or they set the agenda based on the consultations that are held as a first step to developing what should we do in working with you to advance your health and well-being, make you part and an active player in your family decision-making, your neighborhood, and wider community settings. So we undertake an active process of collectively identifying the problems together and understanding the world of people with lived experience and their caregivers and families, as well as roping in other actors in the space, be they women's groups, farmer groups, children-focused entities, or just governmental agencies responsible for social welfare or such other sector. And so working with that, we would see priority for getting well, getting treatment, getting a means to a secure livelihood, getting to belong and benefit from peer support from one another through self-help group processes, and ensuring that activities that are going on promote a sense of care and support and acceptance to person. And it makes reintegration or even integration seamless compared to bringing somebody who was admitted at a psychiatric facility or whatever rehab facility, and after a few months or years, you bring the person back, or the person returns to say, I am well, and I'm coming back into the community. Usually integration is not that easy, but seeing families that have been there, friends that have supported the person through treatment, and seeing the journey of the person's progress to recovery, reduce symptoms, and doing things for themselves makes it seamless and really doesn't matter. And that whole dynamic or cycle of working in a community setting maximizes the effect of integration, maximizes use of resources. I see that a substantial part of resources are drawn from within the community, within existing structures, be they governmental or non-governmental. To my next slide, that with all these work that has been going on, have supported quite a significant number of people to get back to what everybody thinks is what anybody who is involved in day-to-day activity should be in the area of productivity, work, ability to express yourself, what your problems are, and to get to engage communities to understand more about mental health and support. So these pictures show the activities that we have been engaged in, what the results are, getting people to become key members of their families, where we are now talking of some 180,000 that have benefited in the work of basic needs over the years. And a significant number of these are people who have experienced mental health conditions. I would say, as we say, turn the corner and are not just useful to themselves now and their families. Mm-hmm. So the final slide I'd like to share for us to start the discussions for inputs is that of our impact and scale as per our strategy of work. We had modestly given ourselves some target of 50,000 of which, and I'm proud to say we've almost halved it within no time, with a high scores for access to treatment and reduce symptoms. And in fact, there was a forum where the chief psychiatrist of the Ghana Mental Health Authority said, we need to probably do another study to find out whether we are still at that level of having 90% treatment gap in Ghana. because organizations like Basic Needs have done a lot that the treatment gap would have come down a bit. And I think that is being recognized for the work of Basic Needs. A key part of our work is also supporting peer support groups. And I'm happy my colleague Adam is able to join, and he and his colleagues are doing a fantastic job working with support groups that have found, you may call it solace, and a place to confide in one another, a place to hear each other's struggles and joys over the days, and where everybody is there for the other. And it's a significant game changer in Ghana, mobilizing several hundreds of people, individuals in communities who did not even know about one another, to now check in on each other, going for such social events like religious gatherings like churches and mosques, to explain what mental health is and their own experiences, going to marketplaces, attending each other's weddings and naming ceremonies, as well as such unfortunate events like funerals, and making modest contributions to support one another. Our work with other civil society organizations.
Peter, we are more or less getting to the time out. If you don't mind beginning to bring it to an end, that would be helpful.
Very well, thank you. And I think it's a good point to end about our work with civil society organizations, where through the Alliance for Mental Health and Development, over 109 CBOs are collectively working to advance mental health. And these are the strides that we think are drawing us to addressing the SDGs that relate to issues of mental health. Thank you very much, Chris and Kate, and my colleagues in the panel for this opening, and I'm glad to be part of it. Thank you.
Thank you so much, Peter, for sharing about this. Particularly appreciate the holistic view, the community-based design, and all the work that you are doing to involve those with lived experience. And we'll be sharing the contacts of everyone at the end, so do feel free to reach out to follow up with any questions that you might have. It's my pleasure now to welcome Kate Leventhal, who is the Chief Program Officer of Corestone. And Kate, we're looking forward to hearing your presentation.
Thanks. Thank you so much, Daisy. And hi, everybody. Thanks for having me here, really, as part of this panel. There's so much inspiring work being showcased. I'm so grateful to Monira and to Peter for the wonderful presentation so far. And as Daisy mentioned, please do feel free to contact me later, anybody on this call, with any questions or thoughts. So I'm Kate Leventhal. I serve as Chief Program Officer at Corestone, and today I'll be sharing a brief case study and honestly a bit of a whirlwind tour about Corestone's work in resilience programs in LMICs. So first, I'll just start out with a little bit about Corestone. We like to say we work at the nexus of resilience and social change, and we aim to help youth in particular bounce back from challenges and thrive, improving not only themselves, but also their situations and circumstances by leveraging the amplifying effects of mental well-being promotion programs. So we conduct evidence-based psychosocial resilience programs in low and middle income countries. Next slide, please. We have 6 core resilience programs, and I'm going to mainly talk about Youth First and Girls First today, but I'll just mention all 6 for context. So Youth First is a school-based psychosocial resilience and adolescent health program for girls and boys, and we currently conduct this in India, Rwanda, and Kenya. Girls First is similar, but it's for girls only. InReach is a fully remote program which aims to reach marginalized adolescents to support mental health during and after COVID. The SHG Resilience Project and the Resilience Parent Program are adult programs for women self-help group members and parents of young children, respectively. And ARROW is a program that builds frontline health worker resilience. Next slide, Daisy, please. So Youth First and Girls First, how do they work? Sessions are held for students in grades 7 and 8, and there are between 25 and 32 sessions depending on the location. Sessions are held weekly for 1 hour during school time, and this lasts for 1 or 2 school years, again, depending on the location. Sessions are conducted as teacher-facilitated support groups of about 15 students per group. What I'd also like to highlight here is our overall approach of embedding a cascade model into existing government infrastructure. And this allows us to move towards sustainable institutionalization and scale. So generally what we do is we work directly with government education systems, providing them with training, capacity building, system strengthening, and evidence generation. And we particularly focus on training master trainers who are already on staff within government systems. These master trainers in turn train teachers as facilitators who then conduct sessions for their students. This strategy enables Youth First and Girls First to reach millions of kids. And actually, in fact, over the next few years, more than 5 million kids will be receiving these programs. Next slide, please, Daisy. So all of our programs, including Youth First and Girls First, follow the Cornerstone model. And our tagline actually is that development starts inside, which we really are discovering to be true, both through our experience as well as empirically. So our foundational belief is that if you start with work internal to a person, and these you can think of as essentially mental health and well-being inputs, that's what you see on the left-hand side of this diagram here. A lot of the development outcomes that we're all working towards, like the SDGs, will become more possible. And that's what you see on the right-hand side with the individual and social effects. Next slide, please, Daisy. So as I mentioned, it's not just our model. We've also found that mental health and well-being are foundational to nearly any other goals, including the SDGs, through quantitative and qualitative empirical studies. So some of the SDGs that we've shown are amplified by building resilience and psychosocial well-being are listed here. I'm not going to list every single one of them out right now, but they are the ones that are essentially within the categories of good health and well-being, quality education, gender equality, and actually also clean water and sanitation. We also feel confident that there are many more SDGs that mental health and well-being is related to that are not listed here, but this is just a sampling. Next slide, please. So obviously I can't share all of this evidence right now for time reasons, but I'll at least share a sliver of some of the evidence that we have. This particular evidence speaks to SDGs 3.7, 5.1, and 6.1 regarding sexual and reproductive health, discrimination against women and girls, and access to clean water. The study that I'll draw from is an RCT that we did of Girls First among 3,400 adolescent girls in 76 schools, and this was done in Bihar in India. The study had 3 intervention conditions, as you see here, and 1 control condition. We were interested to see how the psychosocial resilience curriculum functioned on its own and in combination with an adolescent health and rights program. Next slide, please. So I'll highlight just a few representative results from this study here that compare the combined resilience and adolescent health curriculum, which is what we now call Girls First, with the adolescent health curriculum alone. All of the changes that you see here are significantly different between the 2 conditions. And by comparing the reddish bars, I guess reddish orange bars, which is the curriculum that combined both components, with the lighter orange bars, that's the adolescent health curriculum only, you can see that adding resilience to adolescent health amplified the effects of the health curriculum. And that was true for reproductive and sexual health knowledge, that's listed here on the left, clean water behaviors, which is in the middle, and gender equality attitudes, which is on the right-hand side, and that's true among others. You can find the full paper if you'd like, the rest of the results. And so again, reminder, the only difference between the reddish and the orange bars here is that the red had psychosocial resilience added in. There was no difference in the health content that the 2 conditions received. So this study really suggests that if you add psychosocial well-being promotion efforts like resilience into the development efforts that you're already doing, you might get better results, not just on the psychosocial outcomes that you're looking for, but also on other outcomes too, like those reflected in these SDGs. So next slide, please, Daisy.
I think that might be.
That's probably the end. So anyway, thank you so much. Yeah, I'm really looking forward to the discussion if we have time, and any questions, and don't hesitate to reach out to me afterwards. I'd love to hear any comments or reactions. Thanks.
Yeah, we do actually have a couple minutes left over with your time, Kate. So I am just so excited about the mental health promotion and prevention approach that you all take. And so I'm curious from your perspective, why is this part of the spectrum so important when we're thinking about scale and systems?
Thank you so much, Daisy, for that question. It's really important. So I'll relay a really brief anecdote by way of answering that. So I recently spoke to a woman who was working on youth mental health, and it was mainly on the side of diagnosis and treatment. And we were starting to talk about a potential partnership. But as we talked, it became kind of clear she was a little skeptical that prevention and promotion really mattered. And she said to me, you know what? I feel like youth mental health problems are such a crisis. It's basically like this burning building. Everybody is trapped. We just can't afford to focus on anything but getting people out. So what we really need to do is just treat as many people as fast as we can. And that's where we need to focus. So I saw her argument. I always appreciate a good metaphor, but I asked permission to change the metaphor a little bit. And I said, I see what you're saying, but I actually think the crisis of mental health and well-being is much more like a wildfire than a burning building. The reason I say this is that a burning building has a little bit of the illusion that it's contained and it's finite. And once you've saved everybody inside, you're done, right? You've achieved your goal. But that's really not the case with mental health problems. There is not one person on this earth who could say they're immune to mental health problems or to emotional suffering, right? There will always be more people who need treatment if you don't take some measures to prevent the wildfire from reaching them. And this is particularly the case right now, as you mentioned, Daisy, where the huge stressors of today, poverty, inequality, climate change, and COVID most recently, make it even more likely more and more people are going to be at risk. The fact is, honestly, there just aren't enough resources for us to provide only diagnose and treat services to serve everybody. We also need to reduce the number of people who need services. And the advantage of this is that not only can prevention and promotion programs be very low cost and large scale, as I mentioned, they can also provide really valuable skills that everybody needs for their lives, whether they now have or will ever develop a mental disorder or not, right? These mental health and promotion prevention skills are actually kind of skills for thriving and well-being in disguise. And I think that this really cannot be ignored.
Thank you so much, Kate. And thank you so much for sharing about Cornerstone and the amazing work that you all are doing. I want to take a moment just to wrap up and think about what we heard today from Monira, Peter, and Kate. We have so much gratitude for the three of you and your teams and your communities for the work you're doing in mental health and the social change that you're seeing that goes far beyond treating individuals. It's going into spaces of community and connection. You're working on legal policy to change the political environment. You're working within systems that are built, I think, as Peter mentioned, during colonial times. And so you are up against a number of different systems and structures, and yet you're seeing people heal, come back to society, and actually be able to experience flourishing. So thank you all so much for the work that you're doing. And I hope everyone here is able to just see the connection that mental health has with issues we care about: human rights, education, livelihoods, and the reduction of poverty and violence, and also gender. So as we kind of head into the last handful of minutes that we have with you, Chris will share the invitations that we have for you from our Catalyst 2030 Mental Health Collaboration.
Sure. Thank you, Daisy, very much. And a particular thank you to our three speakers. Monira, thank you so much, and Kate and Peter. And it's marvelous, as Peter already indicated, to see so many colleagues, ex-colleagues and colleagues on the presentation here today, on the webinar today. Really great. We've got an invitation to you, which we're going to pull up with a form for you to fill in a second. And we would love you to get involved with this initiative, particularly if you are in any way yourself involved with mental health. It's just come onto the chat now. Do please indicate if you'd like to get involved, particularly with the mental health collaboration at Catalyst 2030. We have another session as a collaboration. We have another session coming up on Friday at 1500 hours CEST. That's the 13th, and that will be led by Daniel Lobo, who is on this program, as well as myself, and we will be very pleased to hear from Elaine, who is also on this. And we are then going to be inviting a number of funders who are going to come to that session as guests, and they will be talking about why they believe that it's important to fund mental health, something which is very important, as you know. There is, at the moment, a very, very marked funding gap between those who are actually working in the field, working in the practice, and the amount of money that they can receive to actually implement this practice is very, very, very hard and often reduced. And I was just talking to a mentee this morning, somebody in Malawi who is working in the field of mental health, and they have just had their budget cut by 26%. And yet there just isn't enough money to go around. So very important to get funders involved so that we can understand it. We are also going to share with you a wonderful document which has just been produced, hot off the press, as they say, which is going to be a booklet about many of the mental health collaboration participants who are involved. There is the link coming up now. We have more individuals who are actually involved in the collaboration, and they will be going into the booklet over the next 6 months or so. But this is certainly a booklet that we would ask you to download and also to share with your friends and colleagues by way of actually indicating, what can be done in the field of global mental health. This has been a very inspirational webinar. It's been fantastic to see these particular presentations and to understand what is happening in the world, the work that's going on, which has been really impressive, I think. And Daisy, I would like to hand over to you to finish the program for today. But just before I do, let me say thank you very much for being such a fantastic co-host. It's been great working with you.
Likewise, Chris. I want to reiterate the gratitude, Munira, Peter, and Kate, for sharing with us today, for inspiring us, for helping us to connect how mental health deeply impacts the issues that matter most to us. And so thank you for being here. Many thanks to everyone who has spent the last 45 minutes to an hour of your day with us today. We do hope that you will continue to be involved with us. So please do take a couple of minutes that are left over in this hour to sign up for the funding session, to indicate any interest in our upcoming activities, and also check out the booklet to get to know our collaboration members so that you can reach out at any time to understand their work a little bit better. The speakers are now Kate, Munira, and Peter. You're invited to please share your information in the chat. I'll give you a few minutes to do that. And then we just want to send you off with wishes for well-being this week. Thank you again for being with us.
There we are. That's great. Thank you, Kate, for sharing yours. Thank you, Munira. Do share yours. That's great. Thank you, Peter.
Thank you, Peter.
There we are. That's great. If you'd like to take any of those contacts, you're very welcome. Great.
Thanks everyone for being here. Have a wonderful morning, afternoon, evening. Take care.
All the best.
Thanks so much, everybody. Thanks, Daisy and Chris.
Bye.
Bye.
Many thanks, Chris.
Thank you, Daisy. I think that went very well. We had some, really good talking. I think some good speakers, which was great, and that was great. Went very well. Yeah.
Great.
I think we can leave it there now, don't you?
Yes. Yes.
All right.
Best wishes for the sessions you have remaining this week. I'll be there for at least the funding one.
All right.
Take care. We'll be in touch.
Thank you. Take care. Bye. Bye.